Hey guys, down here, welcome to Podiatry Practice Mastery. I have a doctor, Dr. Stu here, is an anesthesiologist that's visiting me today in the clinic. He's here to learn a little bit about ultrasound because he had worked as before retirement in a regenerative practice, kind of with backs, and he's kind of coming here thinking about doing feet. So welcome to the podcast here, Stu.
Good afternoon, everyone. As Don mentioned, I'm an anesthesiologist by training. I did 25 years of hospital anesthesia, and then I transitioned into a interventional pain practice with a colleague. So the two of us had an independent, freestanding practice that had no formal ties with any hospital. We started off probably seeing 12 patients a week, and in our heyday we're seeing 50 to 60 patients a day, and so it became a very successful practice. We were very proud of it, and I did that until a few years ago when I became a grandfather and helped out my daughter with some grandfathering, which is a great pleasure. And I'm interested in doing some work once again. During my interventional pain, I moved from cortisone injections to a form of regenerative medicine with PRP therapies. We did it into the knee, we did it into the hip, we did some facial rejuvenation work. And I've lately made contact with a colleague in my home area of southern New Hampshire, and we're interested in beginning a PRP practice within his podiatry practice and doing, for me, part-time work doing PRP for plantar fasciitis and possible tendinopathies, Achilles tendinopathies. My experience is using fluoroscopy for my guided injections, and I feel it's important to continue to have a guided injection, and that's why I'm visiting Dr. Pelto he's going to help me with getting familiar with ultrasound-directed injections into the foot. And it's been an eye-opener visiting his practice this morning. He's quite the dynamic guy with many, many interests, and I'm enjoying my visit and seeing a lot of new technology. I've been very impressed with the shockwave therapies that Don is doing. And between the two of us, we're thinking that maybe there's some similarity in the way these days acetaminophen and ibuprofen both turn out to be synergistic for pain management. Possibly shockwave therapy together with PRP could be a very good or great combination for people with plantar fasciitis or possibly other problems.
So Stu, we were talking here, we were using amnio, but the price has really gone up. So one option is finding another amnio company. I guess maybe another option would be doing PRP. The problem for us is drawing that blood and spinning it down in the room that's occupied. The whole procedure, Stu was saying, takes about an hour, maybe a little bit less. So you have to have him sit in a room, draw it, spin it down, prepare it, and then inject it. And for us, something that's off the shelf works a little bit better. When he was in private practice, he said he had about a 20% cash pay. So still a lot of steroid, but then there were ones that were transitioning to PRP or wanting that PRP cash pay type of treatment. Similar to ours, I think our number is about 25% cash pay, and you have to learn how to explain things to patients. And you said a few things I liked. You were talking about like 30, 30, 30, and then what other kind of words as you were kind of explaining the options they could do, cortisone or the traditional treatments or the regenerative? How do you kind of explain that to patients?
Well, I used to start off with what I call PRP 101, and I would explain what PRP is and how it works and how it's different than a medication, basically because, in quotations, I would say it's your own stuff. And that was somewhat of a selling point that people would hear, that it's coming from your own body, and very quickly If you get a little paper cut, platelets come to the skin, and in a day or two you don't have a scar from that paper cut. So and that's at a concentration of 1. If you can, through the PRP techniques, you're going to really increase that concentration and give you much more regenerative power. So people appreciate the fact that you're harnessing your own curative strength and are willing to give it a try. I think your allies in trying to convince people are, one, that it's your own stuff, you're not going to be contaminated. 2, that it's been working already in your body at a concentration of 1, so you're going to be at a concentration of 5. And if you're in a lot of pain and you're in a pain clinic and other therapies haven't worked, that this is a very reasonable investment of your time and money.
Now, Stu, how often did you try the conservative or insurance-covered things first before you switched to the PRP? Like, was everyone doing cortisone first, and then a month later, then they would transition to that? Or can some people, did they want to just do the PRP?
When I explained it to people, for the most part, it's just as you described, that they'd like to, there is somewhat of a phobia or a non-likeness of wanting to pay for medical treatment, especially if you have health insurance. So most people did want to try cortisone therapy or a more traditional, which is very reasonable, and we were more than happy to treat them if it didn't work and go to the more advanced type of medication with a PRP.
Yeah. And how many PRP injections were you typically doing?
Per patient?
Yeah.
Yep. Most of my patients, I only did 1.
1.
Yeah. And I could say, like that old hair commercial, not only am I a provider, I am a patient.
That's perfect.
And when we did the first one, my partner didn't do PRP treatments, so I had to guide him through, taking care of me, but I had it done on my right knee, and I got tremendous results.
After failing cortisone?
After failing cortisone, I went to orthopedic colleagues, and they gave me a cortisone treatment. It just didn't help. But the PRP for me, and like anything in medicine, it's not going to help everyone. But for me, it was great. And I think being able to tell patients that I've had it, I think that made them feel good too.
I think it does. It's kind of like when we wear orthotics and we talk about orthotics or anything else.
Yeah.
If someone had a cortisone, I tend to wait a month before I'll do a regenerative treatment. How long did you wait after?
At least a month.
Okay.
Yeah, a good 6 weeks. And
to make sure it's out of your system, because it'll work against it. Right?
It seems to, yeah. I mean, the basic way, the most easy way to explain cortisone is anti-inflammatory. And, of course, when we do regenerative, we want to get the inflammation realized by the body and bring out the tools that the body has to treat that inflammation.
Yeah, good.
Mm-hmm.
So tell me, so now no one ever, so just so you know, everyone that's listened to this podcast, I've invited you multiple times to come to my practice, and Stu was one that came into my practice and was able to kind of see how I treat, the use of technology, the staff. Now I'm making this invitation again. If you want to come and visit me, I always say it's free for me to visit. If you want me to visit you, it's going to probably cost you $10,000. Because it's time away from the office. But Stu, what has been your perspective on how the practice is run, kind of what things that stuck out to you after being in practice for so many years?
First of all, I had a line, a picture's worth 1,000 words, a video's worth 1,000 pictures, and an office visit is worth everything. Mm-hmm. You get the whole gestalt of the office. And we all recognize that there's not always the science of medicine, but the art and science of medicine. And I think when you see someone with good patient technique and ability to connect to the patient, together with how you interact with the staff, it's a big picture. And I think the only way you really can benefit from that big picture is with a visit. And I think it's it's penny wise and pound foolish not to do it. I think you're going to take time away from your practice or away from your family. It's well worth it.
Yeah, yeah. And I think a few things you mentioned that you liked were like the use of a scribe, you know, how that works, the use of the technology, the you know, the things like that.
Well, it's fascinating the way Don Pelto uses the scribe. It's almost indescribable.
It's kind of like you did the same thing when you transcribed, though. It's very
Yes,
similar to transcription.
It is, but you know what's different is that when you hold a dictate in front, it's one way. You have interaction with your scribe.
Yeah.
And I think your scribe, from my brief observation, is a lot more than a scribe. It's almost a practice coordinator.
Yeah, personal assistant. He orders x-rays. He puts the x-ray order in. He does the review on the x-ray, writes out what it is, orders medication, puts in referrals, puts in surgeries. He's like a personal assistant. You know, you could have a scribe in person do that, but I find to keep them, I find having a virtual one works a little bit better. Plus my rooms are kind of small in my other office.
Not only that, but as you mentioned to me, it takes a lot of time to train someone. And this way you have a strong relationship, and I think, you know, the two of you will stay together, and it'll be a good investment for all your time to train him.
Yeah. So Stu, last thing I want to ask you about is there's a trend in podiatry where we're doing a lot more in-office. We call it MIS, minimally invasive surgery. And in the past, you used to go to offices as an anesthesiologist. Now it's more of CRNAs that come to the office. Sometimes offices, they buy their own anesthesia stuff, and the CRNA just, you pay for their time. Other times they bring in everything as like a mobile anesthesia unit.
Anesthesia to go.
Yeah. So what are your thoughts on that in terms of efficiencies? Is it an expensive build out to get accredited? Because you did some evaluating of those as well.
That's a great question. And it's a very, very interesting way to go. It is a huge investment, but when done right, I think it's well worthwhile. And if you think just about the efficiency of your time, that's a huge one. You're not traveling to a hospital or a surgery center, and if someone doesn't show, you can do something in your office as opposed to sitting on your rear end in the ambulatory surgery. And in terms of the anesthesia, that's where the field of anesthesia has grown over the last 20 or 30 years. The introduction of propofol and a propofol drip can make office-based, that's what we called it, not outpatient, we called it office-based anesthesia. And there's truly a subspecialty field in that. One of the things that I do is I'm a surveyor for the Quad A, that's the American Association for Accreditation of Surgical Facilities, and I go to outpatient places where full anesthetics are given, or facilities with just local anesthetics, and some facilities with a combination, which I think is great, of giving some propofol, almost like in a colonoscopy. Often colonoscopies are done under propofol, and then it really increases the efficiency and the time management of you get more procedures done in your facility. And then if you have the right personnel to work out the logistics of payments, you have another stream of income for the surgical procedure besides just your procedure as the doctor providing the procedure.
Now, I interviewed someone before about this, and I think a lot of them are like eye doctors and maybe colorectal, because they do a lot of these procedures, screening/procedures. They're very quick. Not many instrumentations are needed. Kind of the objection to some of my colleagues are like, these cases we're doing might take 3 hours, and you have to have C-arm, you have to have tons of screws, you have to have all these other things. So I think you would almost, unless you had all of that stuff or the reps would bring them in, you would probably do simpler procedures in the office that are less time, like 20-minute, 30-minute cases. Is that how it is?
Yes, I would agree with you. And it's possible to develop sort of a subspecialty within your subspecialty and have certain procedures that you do really, really well. I've visited plastic surgeons that will do a 3 or 4 hour case, and have all the equipment to do it. But I think the money is made, or it's more profitable with the shorter procedures that you can turn over quickly. Turnover time in operating rooms is huge. It's less in a ambulatory surgery center, but in office space, if you have a good staff, you can just really minimize the annoyances of wasted time and make some money. And I think your point is well taken. You want to choose carefully what procedures you want to do. And remember, you want to walk before you run. Start off with simple stuff, and then as you're successful, consider more complicated procedures.
Great. Well, Stu, thanks for coming by. I appreciate it. And anyone that's listening, please, if you're interested, just shoot me an email, don@podiatrypracticemastery.com. I'd love to have you come out, visit the office. I know you'll take away some great tips.
I couldn't agree more. It's been a pleasure. Thank you.